Hi, everyone, and welcome to the fiscal year 2025 ongoing competency for Silver 9, Silver 12, Founders 10, and Founders 12. Please watch this brief video and then complete the quiz questions using the QR code at the end to receive credit for completion. You must obtain a 90% or higher to receive credit for this competency. If you do not obtain 90%, you may retake it again as many times as you need until you pass. Catheter-associated urinary tract infections have jumped significantly at Penn Medicine, threefold almost, from FY 2020 to FY 2024, and Penn has made some significant changes in order to address this. So why do we care so much about CODIs? First, CODIs are common, and in fact, they are the most common hospital-acquired infection nationally and increase a patient's length of stay an additional 3 to 5 days. In addition, treating a CODI is expensive and costs the hospital almost $28,000 per infection. The duration of the catheter is one of the single most important contributing factors for developing a CODI, and 30 to 50% of catheter days are found to be unnecessary. And finally, the majority of patients develop non-infectious complications after having an IUC, including urgency, leaking, pain, and skin breakdown. Penn Medicine has created a CODI prevention bundle solution. First, we want to prevent unnecessary IUC placement and consider alternative external devices, such as the PureWick. We want to use new pen chart orders for nurse-driven and provider-driven removals, follow evidence-based aseptic technique insertion if an IUC is indicated, follow evidence-based IUC care and maintenance standards while that IUC is in place, and finally, we want to prioritize prompt removal and prevent reinsertion following the bladder management pathway.
As we know, the single most effective strategy for CAUTI prevention is to avoid Foley catheter placement to begin with. Here at Hub, we have several alternative urine collection methods that can be utilized in lieu of indwelling catheter placement. These methods have demonstrated to accurately measure urine output at the same efficiency as an indwelling catheter and pose exponentially less infection risk to the patient. External urinary catheters are available in the form of a PureWick device as well as a Texas catheter. Texas catheters are also frequently referred to as condom catheters. For those patients who are continent of urine, measuring output is easily achieved through the use of a urinal or commode. Additionally, urine output can be measured through weighing of the patient's briefs or incontinence pads after each void. Please note, weighing of briefs and pads for urine output measurement requires the use of the specific scale. Please check with your unit CNS or CPL to determine whether this practice is currently available to you on your unit or if you express an interest.
All orders for an IUC must include the indication and an IUC removal plan for provider and nurse-driven removal orders. For provider-driven removal orders, the nurse will still need to assess and document the necessity of the IUC every shift. The nurse should work with the team to develop a plan for IUC removal, and when it's indicated, the provider will place the order to remove the IUC. For nurse-driven removal orders, the nurse will assess the need for the necessity of the IUC every shift. And in this case, if the IUC is no longer indicated, the RN can document that it's not indicated and removes the IUC without needing to obtain an order from the provider. Once the IUC is removed, the RN documents the removal date, time, and when the patient is due to void. The IUC LDA can be completed in the EMR at this time. Here is a list of the IUC indications for Penn Medicine. Again, the provider-driven removal indications will require a provider order for removal. These include indications including acute urinary retention and accurate I's and O's. Nurse-driven removal indications include open sacral wounds, routine post-op care, and some cases of patients with acute urinary retention with a previous IUC removal.
Maintaining aseptic technique is paramount when placing an IUC. To ensure that this aseptic technique is maintained during catheter placement, the nurse should ensure that they have all the available data, supplies, and support needed for insertion. This includes checking the IUC order to ensure the order indication aligns with the patient's current condition. Additionally, the nurse should find a second person to assist with the IUC insertion process and help with visualization and support if needed. Pericare should be completed prior to opening the sterile IUC insertion tray or prior to donning sterile gloves. After completing this pericare, remove soiled gloves and perform hand hygiene. Do not apply sterile gloves directly on top of clean gloves. Ensure the patient understands the procedure before proceeding and that they are appropriately positioned. For patients with IUCs, catheter care and maintenance are critical and can help to optimize early IUC removal and also greatly reduce the patient risk for infection. Catheter care and maintenance workflow includes the nurse's assessment and documentation of the continued IUC necessity, as well as the indication every 12 hours. ensuring the catheter care with CHG, unless CHG is contraindicated, is being completed every 12 hours. Make sure to maintain a closed seal, a catheter securement device, and properly position the urine drainage system. Ensure that urine flow is unobstructed and that no dependent loops are present within the IUC system. Ensure that you are changing the securement device every 7 days. Emptying of the drainage system should be done and documented at least every 8 hours. And or if the drainage bag output is greater than or equal to 400 milliliters, should also be emptied each time prior to patient transport. Few catheter care do nots. Do not place the urine drainage bag on the floor, the patient's bed, or on the mattress or stretcher during transport. Do not allow the urine drainage bag and the port to touch the inside of the urine container. And do not ever clamp IUC tubing except for when obtaining a urine specimen. CHG bathing is one of our best lines of defense for fighting germs and proactively working to prevent any source of potential infection for patients with indwelling urinary catheters. CHG bathing helps to fight up against germs for up to 24 hours and should be performed daily. CHG bathing is recommended for pericare and can be used on external genitalia only. It is compatible with all hospital supplied lotions. To perform CHG bathing, apply the lotion directly to the skin or washcloth. Do not dilute it with water or in a basin. Wash with the CHG from the chin down. CHG should not be applied to the face. Once completed, rinse off the CHG thoroughly with clean, warm water. Please note and remember the time documented on the MAR that the CHG was dispensed and given must match the actual documented bath time. After CHG bathing, do not use any regular soap and avoid the use of CHG products on areas of skin breakdown. So just a simple overview of dependent loops. A dependent loop is a portion of the tubing in a urinary drainage system positioned in a way that causes urine to accumulate in the tubing and eliminates outflow of urine from the bladder. In order to maintain an unobstructed urine flow, ensure that you are arranging the tubing so it ensures proper flow of urine into the drainage bag. Utilize the green clips on the sides of the tubing to secure the tubing to the bed sheets if necessary. Each time we are performing safety checks or doing any kind of turning and repositioning, patients are transferring to and from the floor. It is essential that we are assessing the entire system from the site of insertion all the way down to the drainage bag to make sure that we are free of dependent loops, kinks, and that everything is still maintained and intact.
This is how the bladder management orders will appear in PennChart. First is the order to place the IUC, which will include the indication and whether it is provider or nurse driven. Then you will see an order for ongoing care for the catheter, followed by a discontinuation order and whether it is appropriate for removal via the Penn pathway. Here is a sample of the required nursing documentation associated with the bladder management order set, which is completed by nurses each shift. The first picture is an example of the indications for the catheter, which include acute urinary retention, routine post-op, provider-driven, comfort care, and sacral or perineal wounds. The bottom picture is focused on bundle compliance. Ideally, nurses should document WDL, which indicates that all infection prevention measures are in place. However, if any items are missing or excluded, they should be documented with an X.
To assist with prompt IUC removal and avoiding reinsertion of the catheter, you can reference the evidence-based bladder management pathway located on the intranet, which will provide a guide for frequency of bladder scans and intermittent straight catheterization in a 4 to 6 hour cyclical timeframe. This pathway was previously called the spontaneous void trial pathway. Taking a closer look at the pathway, you can see that guidance is based on the volume your patient is retaining. Therefore, your initial intervention will always be to bladder scan your patient and determine next steps from there. Of note, there is no time frame or max number of times a patient can be intermittent straight catheterized. The pathway can be repeated every 4 to 6 hours continuously. Throughout the pathway, there will be mention of updating the provider. Specifically at the 24 and 48-hour mark, if the patient is still retaining urine, discuss their fluid status, concerns for constipation, and other underlying causes of retention. As a reminder, these timestamps are not meant to be a point at which the IUC is replaced. it is still safe to continue intermittent straight catheterization beyond this point.
When patients with an IUC have a potential infection and samples need to be sent, it's important to consult the evidence. Our PEN pathways, also known as Agile MD, provide evidence-based guidelines on how to proceed with many things, including the signs and symptoms of a CAUTI. You can access these from the homepage on the internet. Below is a screenshot of some of the signs and symptoms that could be suggestive of a CAUTI. They include fever greater than 100.4, hypothermia with a temp less than 96.8, rigors, delirium, acute hematuria, pelvic discomfort, suprapubic tenderness, and CVA tenderness. It's important to note that urine samples are never sent based on appearance, and it's always good practice to recheck an isolated elevated temperature. You should be thinking about the patient's whole picture. Consider things like other vital sign changes, white blood cell counts, and mental status changes. Once you've determined that a sample is appropriate for sending, it's critical to obtain it from a clean catheter. This pathway also includes guidance on when an IUC needs to be changed prior to sending any kind of samples. As you can see here, any IUC that has been in duration greater than or equal to 7 days, the catheter should be changed prior to sending any sample.
Let's discuss key takeaways from this presentation. Number 1, the longer Foley is in, the greater the patient's risk for infection is. Number 2, strict intake and output can be obtained by using external devices, daily weights, and other measures of intake. Number 3, daily CHG bathing is an essential part of infection prevention. And lastly, reference the bladder management pathway after an indwelling catheter is removed to avoid reinsertion.